Hello everyone. We are going to be talking about fluid and electrolytes here for our lecture for Monday, September 25th. And just a review of the basics, we know for water, for an adult's body, it's about 60%. It all actually depends on the gender, weight, overall health, and this number can vary, but it's usually around 60% of the body will have water in it. The younger the person, the greater percent of water, just like about everything else as far as normal wear and tear and that type of thing. The more fat on a person, the less water they have. Just think of like mixing fat with oil. And then I also wanted just to point out, I do have it on there. 1 liter of water is about 2.2 pounds or 1 kilogram. And then in looking at our electrolytes, we know that the positive ones are called cations. That's just a review of some of the chemistry that you've already had. And hydrochloride, chlorides, and PO2 is actually considered anions, and they have a negative charge. So TBW, which we'll see depending on the unit you're in, and if you are dealing with fluid hemodynamics, in a lot of the units, whether it's NICU, ICU, CCU, it just means total water, body water. It's the sum of all fluids. And again, this varies with age and amount of body fat. So you can see it's a little bit different for everyone. Okay, so distribution of body fluids. We have intracellular, which means in the cell. Extracellular, which is out. And you can see intracellular is about 60% of our fluids. And in the ICF, in the cell, that's what makes us work very well. Extracellular too, but if we don't have these fluids in the cell, things start happening in a pathophysiological way. Extracellular, outside of the cell, it's only 35% of fluid. And that does include plasma, which is only 8%, and then interstitial and lymph, which is about 25%. Transcellular, which is cerebrospinal fluid, GI, tract, lungs, and heart. Transcellular, it's just what it means. It's fluid between the organs and the tissues. It can be in the peritoneum, pericardial, and pleural spaces. Pericardial is going to be around the heart. Pleural spaces is in and about the lung parenchyma. Major compartments, which we will discuss in depth. Here is ICF, intracellular is potassium, ECF, extracellular is sodium, and they need to stay in those compartments. When things go haywire, we have diseases because these two compartments are not maintained. Pediatrics, 75 to 80% of body weight, so they're actually a little bit more than adults. Very susceptible to significant changes in body fluids, probably because they are more of body fluids. Dehydration in newborns can be deadly. Aging, decreased percent of total body water, just because everything is decreased. Increase in adipose and decrease in muscle mass. As you get bigger or older, that's why they say to keep exercising, because your muscle mass has deteriorated. Increase in fat, well, something has to add to it. And again, if you exercise, hopefully you won't have an increase in adipose tissue. A renal decline, just because the vessels leading into the kidneys, they work continually for us 24/7, and sometimes they can just end up getting tired. Diminished thirst perception in the elderly also. So regulation of water balance. How do we regulate that? A couple of main entities is we retain water by the antidiuretic hormone, ADH. Antidiuresis. Diuresis means they're getting rid of water. So anti against that would be holding on to it. Retention, adrenal mineral hormone and glucocorticoids, they also retain water. Intake and output. And nurses, we are very much responsible for what the patients take in and what they put out. We're measuring urine, we're measuring all kinds of different outputs of tubes and things. And then intake, what are they taking in? How much water are they drinking? GI intake, it can be 2,000 to 3,000 cc's in 24 hours, depending on how much you're drinking. Insensible losses, because we really can't measure them, from the skin and the lungs. And then kidney function. It depends on how good is that kidney function. Are we having trouble? Fluid loss from cardiac function, our natriuretic hormone, and could cause vasoconstriction and secretion of urine. So just to sum it up, the ADH triggered by the pituitary, its impact is on the kidney. So it's triggered by the pituitary in the brain, impact is on the kidney, and it basically is saying, I'm not going to pee a lot hormone. I'm going to hang on to it. Additional hormones that balance fluid, primarily aldosterone and adrenal mineral hormone. Insensible losses are going to be sweat, breath vapor. Water balance is regulated by the sensation of thirst and by our ADH, or antidiuretic hormone, which is secreted in response by an increase in plasma osmolality or a decrease in circulating blood volume. So again, water balance is going to be regulated in response to increased plasma osmolality, or a thickness of the plasma, or a decrease in circulating blood volume. Natriuretic peptides, what are they in the cardiac function? In the atria, we have large vessels in the head, neck, and brain. It can be replicated, and it's a wonder drug. It's by looking at the peptide we can see how far into heart failure they are. So again, very, very important are these natriuretic hormones. Okay, let's start. We're going to start with sodium. Sodium is one of the powerhouses, and we know that sodium is found in the ECF. It's the extracellular fluid cation. And what is a cation again? It's a positively charged ion, whereas the anion is negatively charged. Normal range, and you have to know the ranges of several of these electrolytes, is 135 to 145. Major functions, it's water balance. When you think of sodium, you think of water balance. Sodium is regulated by aldosterone, which increases reabsorption of sodium from the urine into the blood by the distal tubule of the kidney. Renin-angiotensin, we know, are enzymes that promote secretion of aldosterone and thus regulate sodium and water balance. Transmission of nerve impulses. Sodium deficits can lead to neurological changes. Basically, if you don't have enough sodium or hypersodium, people can have seizures. We eliminate it through urine, sweat, and feces. Again, it can cause severe neuromuscular irritability and problems with acid-base balance, cellular chemical reactions, and membrane transport. So hydration, when we're looking at fluid volume, fluid volume deficit for a nursing diagnosis would be one for dehydration, because they're dehydrated, so they don't have enough fluid. Whether they're in a hypotonic, hypertonic, or isotonic state. So let's look at those words for a minute. What does isotonic mean? It's equal amount of solute and water. Hypertonic, we have more solute and less water. More solute, less water. Whereas iso, they're equal on either side. Hypotonic, we have less solute and more water. Okay, we can have that peripherally and centrally. So hypotonic, one of the examples I can come up with is you got 20 people inside of an elevator, but there's only one of you. Inside the elevator is hypertonic compared to the lobby. In the lobby, there is only you and maybe two other people. We would be hypotonic. Does that make sense? When compared to the crammed elevator. So in the elevator with 20 people, it would be hypertonic. When only one of you outside, as far as volume, and that's all we're talking about when we're talking about sodium and water, hypotonic would be the one person standing outside the elevator, one or two people. So hypernatremia, what is that? Hyper, Na is sodium in the blood. We have too much sodium in the blood. It's when sodium, remember the normal value is 135 to 145. It's greater than 145. The causes of too much sodium in the blood is water loss. We have water loss or we have too much sodium gain. Sodium intake by IV, can be more than the water intake if we're giving them too much sodium in an IV. Diabetes insipidus can be a problem. It's what happens is it's in the brain. It's not to be mixed up with diabetes mellitus or sugar diabetes. It's too little antidiuretic hormone is produced. Remember, antidiuresis, we're going to hold on to the water. Well, too much of it is being produced. And the other is enough produced, but the kidneys are not responding. So there's two different ways to get diabetes insipidus. It's either too little ADH is produced, so we're not holding on to it because we don't have that antidiuresis hormone. It's all the water is going out. Or there's enough produced, but the kidney's not responding to the ADH hormone. So two ways you can get it, where you're just, with both of them, you're losing all the water for whatever reason. The kidney's acting up or the brain is not producing enough ADH. Even when the person with diabetes insipidus is dehydrated, the kidneys will excrete abundant dilute urine because it's a disease process. So it's just going to keep pouring the water out. Or it can be too much salt intake, too much sodium going into the cell. Water will go in with it, and then we have ankle swelling or edema. Water follows sodium. Just remember, it's water balanced with sodium. Water follows sodium. What does this sound like it's going to lead to if there is no help with this person? Shock. What type of shock? It's going to be hypovolemic because it's all going into the cell. Chloride levels are generally proportional to changes in sodium levels. So usually sodium and chloride go together also. And then our atrial natriuretic hormone also is involved in decreasing tubular reabsorption and promoting urinary excretion of sodium. Symptoms: thirst, dry tongue, restlessness. They can have weight changes, obviously, if you're hanging on to everything or if you're getting rid of all of it. Elevated blood pressure, bounding pulse, because we've got all of this, too much sodium, so we probably have too much water. Increased moist respirations or crackles, shortness of breath, elevated central venous pressure. And the treatment would be water restriction medications. And obviously, we have to treat the underlying cause. Okay, I'm going to talk about hyponatremia in the next video.